Welcome back to the Means Report. So happy that you are staying with us as we cover some issues that are very important to women, especially when it comes to women's health. We talked about ovarian cancer in our first segment. I want to move on, to some groundbreaking research that's being worked on at the Medical College of Georgia at Augusta University right now in the area of breast cancer. And leading the way is breast pathologist Dr. Ravindra Kolhe, also an assistant professor over there. Thank you for taking the time to be with us today. We appreciate it.
Thank you, Ray.
Let me ask you about this breast cancer research that you're doing. Is it fair to say, if I were to summarize it, that you're studying the recurrence of breast cancer in women who've had it and trying to prevent that recurrence or address that recurrence?
Correct. So,
and it's a 10-year deal?
Correct.
All right.
So what we're trying to understand is, can we identify and separate breast cancer patients who will come back with a local disease and who will not? If you go back and look the way we used to treat this patient 5, 10, 15 years back, everyone who had a breast cancer used to get chemotherapy.
Right.
But the research which is happening in the last, I would say 10, 15 years, we're trying to understand the aggressiveness and the recurrence of the breast cancer in these patients. And now the test which we already have launched at MCG, which basically predicts a probability of local recurrence of breast cancer in these patients.
This is the Prosigna test?
Correct.
How does it do that? How does it predict it?
So the way the breast cancer therapy or diagnosis happens is, if you find a lump in your breast, you go to a radiologist and you do a mammography. They take a small tissue out, a piece of your breast lump. They send it to me, I look at it, and I make the diagnosis whether this is cancer or not. If it's a cancer, then I grade it, whether it's low grade or high grade. We do the staging studies, we look at the biomarker studies, and then we give this back information to the surgeon. Mm-hmm. And the surgeon takes out that piece and again send it back to me, and then we do a thorough analysis of the lesion or the tumor, and we discuss this in a multidisciplinary breast meeting or tumor board, what we call it. And then we go over each and every patient. In this meeting, we decide what to do next with this one individual patient. Does she need chemotherapy, or does she need radiation, or does she need only hormone therapy? And this is probably the closest we are trying to come up with the personalized precision medicine. We are trying to get individual data out of from each and every patient and see how individualized treatment plans we can come up with for them.
So when you're talking about the likelihood of recurrence and you're looking at the cells, how do you separate the aggressive cells that would lead to that recurrence from the normal cells that are doing no harm?
So with the research experience or evidence from the last 15 years, we have put together this test which looks at 50 genes which are expressed in aggressive tumors and few genes which are not expressed in aggressive tumors. Mm-hmm. So we put together this test, and we'll look at the gene expression of these 50 genes, and based on that we have a specific population of patients, especially the patients who have a lower stage of tumor, who have postmenopausal, who have hormone receptor positive, and we perform this test on them, and then based on the expression of these 50 genes, we can predict that whether these patients, what percentage of these patients, or what are the chances of the patients to have a local recurrence, and divide them into low risk, intermediate risk, and a high risk.
Is it possible to treat someone using chemotherapy and only kill those aggressive cells, or only target those aggressive cells, or is that impossible on the chemo front?
So the problem with chemotherapy, it does kill the aggressive cells, but also it does a lot of other side effects, like it goes on your bone marrow and inhibits your regular white cell production or red cell production. It affects your skin, you lose your hair, and there's a general issues with chemotherapy side effects. We really want to separate the patients who would not require chemotherapy, because if you have a less than 10% chance of having a local recurrence, you are better without the chemotherapy, because the radiation and the hormone therapy will take care of that 10% aggressive cells, or 10% of chance of local recurrence.
So now, and as you mentioned at the beginning of the interview, it's no longer presumed that just because you have breast cancer surgery, you're going to have to go through this chemo treatment. You may be able to eliminate that and say, no, what's best for you is hormone therapy.
Absolutely, and this is what we had, fortunately, for our first patient we tested on, and she consented to be a part of this success story. Is she had a low stage tumor, hormone receptor positive, but if she would have came back 15 years back, she would have definitely got the chemotherapy as a part of a routine treatment plan. But after doing this test, now we know that she does not need that chemotherapy.
Do patients have to ask for this test? Say, hey, please put me on the Prosigna program to make sure the right treatment is used on me, or is this something that's just being done to all patients now? Where do we stand?
So if you belong to that category of low stage, hormone receptor positive, and without any metastases, this is now will become a standard of care.
Wow.
The only thing is we are way ahead as a general institutes offering this test. We are 8th or 9th in the country academic center to offer this to the patients. Hopefully in the next 3 to 5 years, we think that this will be a standard of care for everyone who will have a breast cancer and who will fall in this group.
Yeah, I think that we're one of 8 institutions nationally that's getting to take part in this. Why? Why is that? Is it what Dr. Naley alluded to, that we are on the map, that we are getting some credibility around the country and around the world? Is that why these sorts of protocols and programs are starting to come to us?
Absolutely. We are the only state institution. We are the oldest medical and the biggest medical center in the country. It gives us a lot of opportunities, and we have these different platforms on campus which helps people like me to bring in new technologies and newer platforms which are either FDA approved or not approved, and try to see what's the next stage or what's going to happen in 3 to 5 years, and see whether we can bring those as early as possible for our local patient population.
You mentioned the early successes of that one patient. Are you already dealing with more, or so far has it just been her?
No, so we tested her. I think we started this 3 weeks back. She was our first patient. We're testing a second patient this week, and we hope that we'll be able to help her to see in which group she classifies, whether she really needs chemotherapy or not.
All right, so we should advise, is it okay, women who are watching, to ask about Prosigna, ask their physician about it, and see if they qualify for that?
Definitely, I think.
If their case meets the criteria.
Sure.
Dr. Kolhe, thank you for what you and Dr. Naley are doing. We appreciate your efforts on behalf of patients everywhere, and I mean, this is getting a ton of attention, and I congratulate you.
Thank you.
Absolutely. Dr. Ravindra Kolhe, our special guest today.